Did you know that your pancreas can actually start to digest itself? It sounds like a science fiction, but it is like a life-threatening reality called acute pancreatitis. In this video, I explain how this happens, how to spot the deadly colon signs, and the critical nursing care that save lives. And fair, fat, female, fertile, and 40. Do you know what those 5F stands for? I'm simplifying the complex Whipple procedure and giving you the easy way to remember the difference between cholecystitis and pancreatitis. First, let's start with a small intro. The biliary system includes the gallbladder and bile ducts. The cytic duct from the gallbladder and the hepatic duct from the liver join to form the common bile duct. The primary purpose of the biliary system is to transport bile from the liver, where it is produced, to the gallbladder, where it's stored, and then to the duodenum, where it aids in the digestion of fat. Bile is a digestive enzyme that helps break down fats. Biliary disease occurs when the gallbladder or ducts become inflamed, infected, or cancerous, impairing the ability of the gallbladder to function normally. Several disorders such as cholecystitis, pancreatitis, and pancreatic cancer impair routine biliary function, and this we are going to cover in today's video.
Research chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters.
Here is the biliary and pancreatic disorders. We are going to cover the introduction, which I said earlier, and about the biliary system, transport and store bile from fat digestion, and the disorders. And here are the disorders that this chapters covers. So cholecystitis with epidemiology, patho, clinical manifestation, diagnostic, management, and nursing management. Acute pancreatitis, same. We have this concept map, and chronic pancreatitis concept map, and pancreatic cancer concept map. So let's start it. Cholecystitis characterized by inflammation of gallbladder typically arise from an obstruction of bile flow. This condition is broadly classified into calculous cholecystitis, which involves the presence of gallstones, and aculous cholecystitis, occurring without stones, glass stones, or cholelithiasis, are hardened deposits formed from bile components that frequently impede the flow within the ducts and the ducts of and around the gallbladder. Epidemiology data indicates a significant prevalence, with approximately 20 million individuals in the United States affected by gallstones and around 200,000 new diagnoses of cholecystitis annually. The incidence of both gallstones and cholecystitis increases with age and is more common in women and individuals of European descent. Common risk factor often remembered by the numeric five Fs. Fair, fat, female, fertile, and over 40 years of age. Also include obesity, rapid weight loss surgery, high intake of saturated fat, pregnancy due to elevated uh, the progesterone, certain genetic predispositions, example like Pima and Chippewa tribes, I hope I said correct, and specific medications such as estrogen, octreotide, and cholesterol-lowering agents. The pathophysiology of gallstones involves their formation in the gallbladder primarily as cholesterol stones, pigment stones from excess bilirubin, or mixed types. Those stones vary in size and can obstruct critical ducts like the cytic duct or the common bile duct. A condition known as cholecystectomy. Acalculous cholecystitis is often linked to biliary stasis, a slowing or cessation of bile flow, which may result from reduced gallbladder contractility or spasm of the sphincter of Oddi. The presence of endotoxin in sepsis is also positioned to contribute to acalculous cholecystitis by causing uh, necrosis, hemorrhage, and ischemia to the gallbladder, or by inhibiting cholecytokine release. While non-complicated cholecystitis often resolve within days, with a low mortality rate, approximately 25% of patients develop complications such as perforation or gangrene, which can lead to a critical illness, and the mortality rate as high as 60%, often due to sepsis. The clinical presentation of acute cholecystitis varies, ranging from asymptomatic to severe pain and tenderness in the right upper quadrant, sometimes accompanied by rebound tenderness or guarding fever and tachycardia. The pain, often described as colicky and intermittent, radiates to the back, and it's triggered by the release of cholecystokinin, which cause gallbladder contraction. A positive morphine sign elicited by pain on deep inspiration during right upper quadrant palpitation is a characteristic finding. Jaundice may also be present due to impaired bile flow. Diagnosis can be challenging due to non-specific symptoms, particularly in older adults and patients with diabetes. Diagnostic procedures include abdominal X-rays for calcified gallstones, abnormal sonography. Here it's the most common and non-invasive method for detecting gallstones and thickened gallbladder. The CT scan, the computer tomography, and hepatobiliary immunodiacetic acid, the HIDA scans, to assess bile production and flow. Endoscopic retrograde cholangiopancreatography allows direct visualization and removal of common bile duct stones. Laboratory findings typically include an elevated white blood cells count, elevated liver enzyme, the AST, ALT, LDH, ALP, and elevated bilirubin, all indicative of inflammation and bile flow obstruction. Medical management for acute cholecystitis involves maintaining nothing by mouth (NPO) status to prevent gallbladder contraction and pain, alongside intravenous hydration, correction of electrolyte imbalances, pain management, and broad-spectrum IV antibiotics. For pain relief, meperidine demerol is often preferred as morphine can morphine can induce spasms of the sphincters of OD. I presented in medical terminology that I'm going to talk about spasms of the sphincter of OD. So the morphine does induce spasms there, potentially exacerbating pain and bile stasis. The demerol, so meperidine, is the preferred option over morphine for cholecystitis. Oral bile acid reduced like ursodiol and cannabidiol may be used for small cholesterol-rich gallstones through their prolonged treatment duration up to 2 years, and cause can lead to patient non-compliance. Dietary modifiers are crucial, emphasizing avoidance of fatty foods, for example, fried foods, ice cream, red meats, heavy alcohol, and promotion of low saturated fat option like yogurt, rice, potatoes, lean meat. Surgical intervention, primarily it's laparoscopic cholecystectomy is the standard treatment. This minimally invasive procedure involves small incisions and carbon dioxide insufflation to remove the gallbladder in cases of complication like gallbladder. Cholecystitis nursing management encompasses comprehensive assessment, target intervention, and throughout patient education. Assessment includes monitoring vital signs like fever, tachycardia, respiratory rate, blood pressure, serum, electrolyte, especially potassium with NG suctioning. White blood cells count, liver enzyme, bilirubin, skin trigger, and pay characteristics. Abdominal assessment focus on distension, bowel sounds, and the presence of morphine signs, rebound tenderness, or guarding. Stool characteristics like steatorrhea, colored stool, and daily weight, along with intake and output, provide crucial information and fluid status. Nursing action involve maintaining NPO status, nothing by mouth, administering prescribed medication like antibiotic, bile acid reducers, analgesics, antiemetics, promoting bed rest in the semi-fowler position, and managing nasogastric tube, the NG tube, suctioning. Patient teaching is vital for postoperative care, incision care, infection signs, jaundice, pain management, activity restriction, the tube management, dietary modifications like low fat, small frequent meals, and recognizing symptoms of replace or complications. We just covered the cholecystitis with epidemiology, pathophysiology, clinical manifestations, diagnostics, management, medical, pain control, diet, surgical, and nursing management. Acute pancreatitis, I say it's the autodigestion and inflammation. So acute pancreatitis is an inflammatory disease of pancreas that can range from mild, self-limiting cases with low mortality to severe life-threatening condition, often requiring intensive care unit (ICU) management. While mild cases typically resolve with full recovery, severe acute pancreatitis can lead to systemic inflammatory response syndrome and organ dysfunction with a mortality rate of 15 to 30%. The condition is more prevalent in males and individuals of African descent. The most common etiology includes the gallstones and chronic alcohol consumption, with alcohol accounting for approximately one-third of all cases. Gallstones pancreatitis occurs due to obstruction of a bile duct or its proximity to the pancreatic duct, altering bile and pancreatic enzyme flow and leading to inflammation. Pathophysiology is that acute pancreatitis is a reversible process characterized by the autodigestion of a pancreas and surrounding tissues by prematurely activated pancreatic enzyme. The autodigestion process can be isolated or recurrent. The precise mechanism of enzyme release is not fully understood, and the severity varies widely. The classic clinical presentation involves the sudden onset of severe epigastric pain, often localized to the upper left quadrant or mid-abdomen, radiating to the back or shoulder blades. The pain is typically deep, sharp, and intensifies within minutes of consuming high-fat foods. It can be constant and severe, lasting for several days, and often worsens when laying flat, with some clients finding that the fetal position, curling up, is recommended for comfort. Associated symptoms include nausea, vomiting, anorexia, abdominal fullness, hiccups, indigestion, fever, tachycardia, and hypotension. The presence of Cullen sign, peri, periumbilical bruising, and Gray Turner sign, the flag bruising, through frequent is an ominous indicator of retroperitoneal hemorrhage and severe pancreatic necrosis, typically developing 24 to 48 hours after onset. Diagnosis relies on a combination of laboratory tests and imaging studies. Key laboratory findings include elevated serum amylase 10 to 20 times normal, elevating within 12 hours, and serum lipase, the most specific indicator, elevating around 72 hours and remaining elevated for up to 2 weeks. Lipase is the most specific test because it stays elevated longer, up to 2 weeks, and is produced only by the pancreas, or whatever's amylase can be elevated from other causes. Other abnormalities include elevated BUM, suggesting hypovolemia or hypercatabolic state. The labs AST and ALT and white blood cells count. A critical finding is decreased serum calcium, which occurs due to fat necrosis leading to chelation of calcium salt. Diagnostic imaging includes abdominal CT scan, the standard for detecting pancreatic necrosis or fluid collections, MRI, ultrasound, and magnetic resonance cholangiopancreatography, Severity scoring system, which is such as Ranson's criteria, the APACHE2, and Balthazar CT Severity Index, and the BISAP are utilized to assess disease severity and predict diagnosis. Medical management traditionally involved strict NPO status to rest the pancreas, but current evidence supports early initiation of enteral feeding to protect the gastrointestinal mucosal barrier. Aggressive intravenous fluid resuscitation with crystalloids like normal saline or lactate ringer at high rates 200 to 30 ml per hour is crucial to maintain intravascular volume, which close monitoring for fluid overload and pulmonary edema. For severe causes, ICU management is essential due to the risk of hypovolemic shock, pulmonary compromise, renal failure, and GI bleeding. Antibiotics are generally not indicated for fever in acute pancreatitis unless necrotizing pancreatitis is confirmed, as fevers are often inflammatory rather than infections. If gallstones are the cause, cholecystectomy or endoscopic sphincterotomy may be performed. For alcohol-induced pancreatitis, managing alcohol withdrawal symptoms is crucial. Medication commonly used include opioid analgesics like meperidine, fentanyl, dilaret, anticholinergics to reduce secretion and relax the sphincter or OD. Histamine blockers, famotidine, and proton pump inhibitors, omeprazole, to decrease gastric acid and pancreatic enzyme, pancrealipase. Prophylactic antibiotics are not routinely recommended due to a lack of evidence supporting improved outcomes. Complications of acute pancreatitis include necrotizing pancreatitis, which carries a high mortality rate and can lead to sepsis, shock, and multiple organ dysfunction. Pancreatic hemorrhage, uh, through rare, is indicated by colons or gray Turner signs, pancreatic pseudocytes, and abscess are encapsulated fluid collection that may require drainage. Pleural effusions, typically left side, can occur due to impaired capillary permeability or inflammation leading to shortness of breath. Acute pancreatitis nursing management involves vigilant assessment of vital signs, oxygen status, and pain characteristics. Abdominal assessment include palpitation for tenderness, guarding, and the presence of Cullen or Gray Turner signs, which signifies severe complication like hemorrhage. Monitoring serum lipase, amylase, glucose, and calcium levels is crucial. The presence of hypocalcemia indicated by Chauvet or Trousseau signs is a direct consequence of fat necrosis and calcium chelation, requiring close observation for neuromuscular irritability. Stool color, the steatorrhea, clay colored, and nutritional intake are also addressed. Nursing action include maintaining APO status, managing NG tube suction, administering prescribed medication, analgesic, antiemetics, histamine blockers, sedatives, antispasmodics, promoting bed rest in the semi-fetal or fetal position for comfort, and encouraging coughing and deep breathing to prevent respiratory complication. Client education focus on appropriate diet, initially carbohydrate rich, avoiding fats and protein, and strict absence from alcohol and cigarette smoking. Acute pancreatitis, this is a concept map, includes epidemiology, pathophysiology, clinical manifestation, diagnostics, management, and complications. This is a table of medication that I just earlier said about acute pancreatitis. Here are the table from table 60.1, the laboratory values associated with acute pancreatitis, albumin, amylase, AST, ALT, calcium, direct bilirubin, lipase, white blood cells count. And the Rayson criteria, age greater than 55 years, at admission and at 48 hours. The white blood cells count greater, and LDH, AST, glucose greater than 200 milligram per deciliter. Chronic pancreatitis is defined as persistent inflammation of the pancreas that leads to irreversible scarring and damage to the pancreatic tissue and surrounding structures. The most common cause is prolonged excessive alcohol consumption. All the other epidemiologies include hereditary disorders like cystic fibrosis, hypertriglyceridemia, hypercalcemia, primary biliary cirrhosis, and autoimmune disorders. This condition is typically diagnosed between the ages of 30 and 40 years old and is more prevalent in men, particularly in cases linked to alcohol consumption, while gallstones related and autoimmune forms are more common in women. The prevalence generally increases with age and many diagnoses occurring around age 62. Individuals of African descent face a 2 to 3 times higher risk compared to those of European descent. A key distinction from acute pancreatitis is its irreversible nature, leading to permanent alteration in both and exocrine, digestive enzyme production, and endocrine, insulin, and glucagon regulation function of the pancreas. Pathophysiology is that chronic inflammation results in fibrosis of a pancreas, which progressively impairs its ability to produce essential digestive enzyme for fat and protein digestion, as well as hormone vital for glucose regulation. This leads to maldigestion and glucose dysregulation. Clients with chronic pancreatitis typically experience chronic upper abdominal pain that may indicate to the back and often worsen after eating or consuming alcohol. This pain is frequently constant and uh, debilitating, interfering with daily activities. In some instances, pain may paradoxically decreases as the disease advances, possibly due to pancreas losing its ability to produce digestive enzyme. Other common clinical manifestations include nausea, vomiting, significant weight loss, despite normal eating patterns due to malabsorption, diarrhea, pale or clay-colored stool, and steatorrhea, oily stools. Jaundice may also be present if bile ducts are obstructed. Diagnostic workup involves imaging studies such as abdominal CT scan, ultrasound, or ERCP to visualize the pancreas and identify structural and or obstructive changes. Laboratory analysis usually reveals elevated amylase and lipase levels, along with elevated serum alkaline um, phosphatase and bilirubin if obstructive processes are present. As the disease progresses and impacts endocrine function, elevated serum glucose levels are monitored due to impaired insulin production. Medical management. This focus on pain control, IV fluid and electrolyte replacement, nutritional support and insulin therapy for hyperglycemia, pancreatic enzyme replacement therapy, the PERT, is a cornerstone treatment for malnutrition and malabsorption, promoting essential amylase, lipase, and proteins enzymes. The gastrointestinal, the GI prophylaxis, and with histamine blockers or proton pump inhibitors may be prescribed to manage increased gastric acid secretion. In cases of significant weight loss, total parental nutrition, the TPN, may be necessary. Crucially, lifestyle modifiers, particularly abstracting from heavy tobacco use and alcohol consumption, are paramount to prevent further pancreatic damage. Surgical interventions such as Whipple Procedure or resection of the pancreatic head may offer symptomatic pain relief or damage for abscess, pseudocytes, but those procedures are not curative given the irreversible nature of the disease. Chronic pancreatitis nursing management involves ongoing assessment of viral signs, which may elevate during pain exacerbation, serum blood glucose level, amylase and lipase levels, bilirubin and alkaline phosphatase, and client weight. Pain assessment focus on the persistent, recurring nature of epigastric and left upper quadrant pain. Abdominal palpation may reveal tenderness or masses, the pseudocytes or abscess. Skin and scleral color are monitored for jaundice, and stool characteristics for steatorrhea or clay-colored stools. Nursing action include administering the PERT taken with milk, swallowed whole, providing GI prophylaxis, ensuring client rest and a calm environment, implementing pain relief measure, and collaborating with a dietitian for nutrition support for increased caloric intake, low-fat diet, TPN. Client education emphasizes strict alcohol avoidance, proper PERT administration, not chewing tablets, limiting dietary fat, avoiding irritating foods, beverages like coffee, caffeine, drinks, and seeking support from groups like Alcoholics Anonymous or um, AI Anon to cope with the chronic and irreversible nature of the disorders. Concept map for chronic pancreatitis, epidemiology, pathophysiology, clinical manifestation, management. Pancreatic cancer, the silent threat. Pancreatic cancer represents a highly aggressive malignancy, ranking as the third most common cause of cancer-related death in the United States. Its prognosis is notably grim, within 5 years survival rate of less than 9%. A significant challenge in managing this disease is its often late diagnosis. Most individuals are diagnosed when the cancer is already advanced, with approximately 80% having unresectable tumors. This delay is largely attributed to the subtle and non-specific nature of its early clinical manifestation and the absence of reliable screening tests for early detection. The majority of pancreatic cancer are adenocarcinomas originating in the exocrine portion of the pancreas, most frequently in the head. The tumors are characterized by rapid growth and early metastases to adjacent organs such as stomach, duodenum, gallbladder, liver, and intestine, as well as distant sites via the lymphatic and vascular system like lungs, peritoneum, spleen. While the exact cause of pancreatic cancer remains elusive, strong association exists with several modifiable risk factors. Cigarette smoking significantly increases the risk, doubling it compared to non-smokers, and it considered a leading preventable cause. Other risk factors include obesity, diet high in fat, consumption of red meat, fried foods, refined sugar, and nitrates. Can be also occupational exposure to certain chemicals. Non-modifiable risk factors include a history of diabetes, especially late onset, chronic pancreatitis, a family history of pancreatic cancer, and Ashkenazi Jewish descent. The risk generally increases with age, most commonly diagnosed in individuals over 60. The clinical presentation of pancreatic cancer is often vague in its early stages. The most frequently observed symptoms include pain, jaundice, occurring in 80% of clients, fatigue, anorexia, and weight loss. The pain is typically described as dull ache in the epigastric area and back, which may worsen with eating or activity and sometimes improve when lying supine, sitting up, or bending forward. Jaundice typically progresses from mucous membrane and the palms and then become generalized. Other signs include pale, greasy stools due to blocked digestive enzyme release, pruritus from bile salt accumulation, and dark amber urine due to bilirubin accumulation. In advanced stages, abdominal distension and ascites may be present. Diagnostic evaluation involves imaging modalities modalities such as ultrasound, CT scan, MRI, and ERCP to identify masses. The definitive diagnosis is established through histopathology, typically via fine needle or excisional biopsy. Angiography may be performed to assess vascular involvement, while no single blood test can diagnose pancreatic cancer early. Routine laboratory tests may show elevated amylase, total and direct bilirubin, and liver enzyme. Fecal fat, trypsinogen, trypsin, and the lipase level can provide insight into pancreatic function. Medical management primarily focus on adjunct therapy combining chemotherapy. Example, the 5-fluorouracil, and radiation to improve long-term survival, particularly for resectable tumors. For metastatic disease, combination of chemotherapy regimens, example, gemcitabine and erlotinib, are used to improve survival rates. When surgical resection is not feasible, palliative interventions such as celiac nerve blocks are employed to alleviate pain caused by tumor compression of nerves. Surgical resection offers the only potential for cure, but it is an option for only a small percentage of clients due to late diagnostic and metastatic spread. If the tumor is localized to the head, neck, or unguinate process, a Whipple procedure, which is pancreaticoduodenotomy, is performed, involving the resection of multiple organs and reconstruction of the GI tract. For tumors in the body or tail, a distal pancreatectomy and splenectomy may be performed. Post-operatively, clients are monitored for exocrine insufficiency and insulin-dependent diabetes mellitus. A crucial safety protocol following complex pancreatic surgery, such as the Whipple procedure, involves strict non-manipulation of surgical placed nasogastric tubes, NG tubes. Those NG tubes are not to be repositioned, irrigated, or checked for replacement, as such action can lead to a breakdown of anatomic site, catastrophic complication. Pancreatic cancer nursing management involves comprehensive assessment, including vital signs, fluid intake and output, monitoring for dehydration and ascites, serum glucose levels due to impaired insulin secretion, weight and muscle mass. Cachexia is common. Pain assessment focus on its location, intensity, duration, and radiation. Abdominal assessment includes monitoring for distension and enlargement. Skin and scleral color are observed for jaundice, and pruritus is assessed. Post-operative assessment includes vital signs, pain, glucose, NG tube output, and surgical site integrity. Nursing action include providing IV fluids, maintaining NPO status post-operatively, until GI function returns, managing NG tube to low suction, with the absolute rule of never manipulating surgical placement NG tube. And if the tube falls out, if it falls out, call the surgeon. Do not put it back in self. So another intervention is by administering insulin for hyperglycemia, promoting pulmonary hygiene, coughing, deep breathing, incentive spirometry, administering analgesics and antiemetics, and providing high-calorie, high-protein nutritional supplements like megestrol acetate as an appetite stimulant. Client education is paramount, emphasizing smoking cessation, um, detailed post-operative care, medication regimens, diet and nutrition, recognition of hyperglycemia, hypoglycemia symptoms, and coping strategies, including palliative care, discussion, and referrals to support group. What is the Whipple procedure? The Whipple procedure is an operation to treat tumors and other conditions in the pancreas, small intestine, and bile ducts. If you or someone you know has been diagnosed with pancreatic cancer, you may have heard of Whipple procedure. This complex surgery is often used to treat pancreatic cancer but is not an option for everyone. Whipple procedure, a major surgery for cancer in the pancreas, bile duct, or small intestine, involving removing the head of the pancreas, gallbladder, bile duct, and part of the small intestine. Less commonly, it refers to Whipple disease, a rare bacterial infection by Tropherema whipplei that causes severe digestive issues and can affect other body parts like joints, brain, and heart. Life expectancy after a Whipple surgery, the pancreatic duodenectomy varies significantly but often involves a 5-year survival rate of 20 to 25% for pancreatic cancer. Through it can be potential cure for some, but with better outcomes for not negative causes and those receiving adjuvant therapy. For non-cancer conditions like expectancy can be normal, but for pancreatic cancer, survival depends heavily on tumor characteristic, spread, lymph node involvement, and overall health, with improvements in surgical techniques lowering short-term risk. The Whipple surgery, the pancreaticoduodenectomy, is a very complex operation with a significant risk involved, including bleeding, infection, and digestive issues. But the safety has greatly improved in experience centers with mortality rates now often under 5% and complication rates around 40 to 50%. The biggest factor influencing risk are the surgeons and the hospital experience, as complex anatomy and potential for complication like leaking pancreatic fluid or delayed stomach emptying are common. The most common complications after a Whipple procedure are delayed gastric emptying, stomach empties too slowly, and pancreatic fistula, leakage from the pancreas connection, often occurring together alongside wound infection, and bleeding with rates varies, but those being the primary concerns for recovery. Um, then we have, after a Whipple procedure, a nastrogastric NG tube is commonly placed through the nose into the stomach to decompress it, preventing nausea, vomiting by draining fluids until bowel function returns, usually for a day or two. Through some newer approaches questions its routine necessity. It helps rest the digestive system after major surgery with patient often starting on clear liquids or sips of water soon after, while the tube is removed once the gut wakes up, often within the first day or two, allowing for gradual diet progression. Pancreatic cancer, the concept map, epidemiology, clinical manifestation, medical and surgical management, and post-operative care for pancreatic cancer. Let's recap a little bit the chapter 60, Biliary and Pancreatic Disorders. So it's vital because number one, it's high prevalence and hospital admission. Common surgeries like gallbladder removal, the cholecystectomy, it's one of the most common surgeries performed in the United States. Widespread impact, approximately 20 million people in the United States have gallstones, with 200,000 new diagnoses every year. Then we have the cancer severity. Pancreatic cancer is the third leading cause of cancer-related death in the United States. Secondly, most important, about chapter 60, we have the life-threatening complication. So the critical safety, acute pancreatitis, this is not just a stomach ache, it is a severe inflammatory process where the pancreas literally auto-digests itself. It can lead to sepsis, shock, and multiple organ failure. Mortality rates, severe acute pancreatitis has a mortality rate of 15 to 30%. Complication of cholecystitis like perforation can have mortality rates as high as 60%. Respiratory risk, because the pancreas and gallbladder are high in the abdomen, inflammation often causes patients to take shallow breath, leading to pneumonia. Um, atelectasis, and even acute respiratory distress syndrome. Third, it's the critical do not touch safety rules is the Whipple procedure. This chapter introduced the Whipple procedure, the pancreaticoduodenectomy. It contains a massive NCLEX safety rules: never manipulate the nasogastric tube, after this surgery. Moving it can ruin the internal stitches, anastomosis, and causes fatal leaks. For the key diagnostic signs and specific labs, you must distinguish between amylase and lipase. Lipase is the gold standard because it is the most specific to the pancreas. Assessment signs, it introduces classic assessment signs that appear on exams, like Murphy's sign, the gallbladder pain on breathing, Coulon's signs, belly button bruising, and Gray Turner sign, the flank bruising indicating internal bleeding. Fifth, number 5, complex terminology. It requires you to master the stones language, the cholelithias, the gallstones, cholecystectomy, stones in the duct, and the cholecystitis, the inflammation. Causing confusing those terms can lead to dangerous medication errors or incorrect care plans. Conclusion: the chapter summary, gallbladder and pancreas disorders. This comprehensive understanding of biliary system disorders encompassing cholecystitis, acute pancreatitis, chronic pancreatitis, and chronic pancreatic cancer is fundamental for safe and effective nursing practice. The question presented herein underscope and multi-phase nature of those conditions, requiring nurses to integrate knowledge across various domains of client care. The analysis of those disorders reveals several critical aspects for nursing professionals. For instance, the specific pharmacological consideration in cholecystitis, such as avoiding morphine due to its physiological impact on the sphincter of Oddi, highlight the necessity for precise medication knowledge to prevent exacerbation of client symptoms and to minimize potential risk. Similarly, the vigilance required for post-procedural complications such as systemic inflammatory response syndrome following ERCP emphasizes the nurses' pivotal role in proactive monitoring and early intervention to ensure client safety and prevent adverse outcomes. In acute pancreatitis, the evolving evidence-based practice, particularly the shift towards early enteral feeding over prolonged NPO status, demonstrate the dynamic nature of clinical guidelines. Nurses must remain current with research to provide optimal care. Furthermore, the direct correlation between pancreatic pathophysiology, fat necrosis, and systemic manifestation like hypocalcemia, evidenced by chest and torso sign, illustrate the importance of understanding interconnected psychological process for accurate assessment and timely management. The prognostic significance of physiological findings like Coulon's and Gray Turner signs further emphasize the need for astute clinical judgment in identifying severe life-threatening complications. For chronic pancreatitis, The irreversible nature of the disease necessitates a long-term focus on lifestyle modifications, particularly the complex abstinence, uh, abstinence from alcohol and tobacco to mitigate further pancreatic damage. The precise administration of pancreatic enzyme replacement therapy, ensuring its efficacy by preventing premature degradation, is crucial for managing malabsorption and improving nutritional status. Beyond physical Beyond physical care, recognizing the addressing the profound psychosocial burden such as hopelessness through support groups and coping strategies is integral to holistic life management. Finally, in pancreatic cancer, the challenging prognosis and often late diagnosis shift the nursing focus significantly towards palliative care, symptoms management, and comprehensive psychosocial support. The absolute adherence to strict safety protocols such as non-manipulation of surgical placement nasogastric tubes after complex procedures like the Whipple procedure is paramount to prevent catastrophic surgical complication. Moreover, the strong link between modifiable risk factors like smoking and pancreatic cancer reinforces the nurse's role in health promotion and primary prevention, even in the context of a devastating diagnosis. In summary, effective nursing care for clients with biliary system disorders demands not only a deep understanding of disease process but also a keen ability to apply critical thinking, adapt to evolving evidence, prioritize intervention based on clinical assessment, and provide compassionate, holistic support. Those practice question serve as a valuable tool for nursing candidates to hone those essential competencies, preparing them for the complexities of real-world clinical practice and the demands of the NCLEX-RN examinations. We just are at the end of the chapter 16. So this video was about the outline of coordinating care with patients with biliary and pancreatic disorders. So we covered the autodigestion, the 5 Fs, and why you never touch the NG tube after a Whipple procedure. If this helped you understand the chapter 60 better, please like and subscribe for more videos, outlines, and I will see you in the next video, part 3 of chapter 60 about NCLEX with high-yield topics about pancreatitis, gallbladder, and the Whipple procedure. So see you soon and bye for now.
We finally made it!
Thank you again for your time and trust. I'm Nurse Mia, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.